Sorry if that was too loud for our Zoom audience. Welcome to the UCCS Speaker Series. This is the fifth event this academic year and our third in-person event. Of course, this series is part of the Center's commitment to bringing evidence into policy. Our policy themes this year, as you know, are rebuilding the public health infrastructure, confronting drought and extreme heat, and addressing the homeless crisis. But today we look specifically at how data can shape our response to public health crises like the pandemic and much more. And we're honored to do that with the help of Dean Ron Brookmeyer. Dr. Brookmeyer is professor and dean of the UCLA Fielding School of Public Health. He's been involved in responses to some of the most important public health crises of our time, including the AIDS epidemic, the creeping Alzheimer's epidemic, and the COVID-19 pandemic. As a biostatistician, his role has been to direct the collection and analysis of data so that data becomes information and information becomes knowledge. I want to repeat that data don't reveal truth by themselves. It's only with rigorous, reproducible means of collection and analysis the data begin to tell stories that, picking up on a theme that was really introduced by Harvey Feinberg several weeks ago, stories that are meaningful and trustworthy. Dr. Brookmeyer is an elected member of the National Academy of Medicine. He received the American Public Health Association's Spiegelman Gold Medal for significant contributions to health statistics. He's a fellow of the American Association for the Advancement of Science and the American Statistical Association. He formerly served as professor of biostatistics at Johns Hopkins and was awarded the Stebbins Medal from that university for outstanding teaching. He is also the holder of many other honors and awards. Just one brief note and then a small additional piece of editorializing. The note is we'll be taking questions live as well as through Zoom. So if you're on Zoom, please just type your question into the Q&A feature on Zoom. The editorializing is this: as students in the public health section, public policy section of our class understand, we've significantly underinvested in public health in this country and in the state. Public health accounts for about 3% of the total US health budget. COVID has taught us an important lesson that pandemics and other public health emergencies happen, and we need to be ready for the next one. So having good data and good ways of translating data into usable information will be critical, and it's really a pleasure to welcome Dean Ron Brookmeyer to help inform us on this topic. Great.
Great, thank you very much for the kind introduction. It's a real pleasure to be here and to discuss policy and data and models, analysis. Data is the foundation of good public health policy. And that's what we're going to talk about today. But first, let me begin with a little history. The earliest attempts at systematically collecting public health data can be traced to John Braunt over 300 years ago. Braunt studied mortality rates of persons in England in the 17th century, and he hoped that would help predict epidemics of plague. In the 1800s, William Farr carried on the tradition of John Braunt, using vital statistics to improve public health. Farr was a physician with a great love for statistics, and then by the mid-1800s in England, some centralized collection of disease statistics was established, and that enabled Farr to quantitatively track and study epidemics. And what he did was chart smallpox and cholera epidemics in England. Farr wrote, "Medical science will advance not by vague speculations, opinions, and assertions, but by registering facts, weighing and measuring, determining relations, and by applying that mighty instrument of natural science, arithmetic and mathematics. And by the early 1900s, influenza, polio, and outbreaks of a number of other diseases increased recognition of the importance of public health data. And states began requiring the reporting of some infectious diseases. And that became the public health surveillance data, what we call public health surveillance data. So what is public health surveillance data? It refers to the ongoing and systematic collection, analysis, and interpretation of health outcome data in populations. Now, why is it so important? First, you have the data, and it's reported timely. You can recognize disease outbreaks quickly and respond. You can track the spread of disease at local, state, and national levels. You can identify and target specific geographic areas of concern where rates are going up more quickly. It helps state and local public health departments better control disease by identifying specific demographic groups that are at greatest risk. The data is key input into models, and that allows you to make forecasts of the future scope of outbreaks. And then once you respond and develop disease control activities to control the outbreak, it allows you, by tracking, allows you to evaluate the effectiveness of your disease control activities. So by the mid-1950s, there was collaboration between the Centers for Disease Control and the Council of State and Territorial Epidemiologists to develop what's called the National Notifiable Disease Surveillance System. Now, in this system, states voluntarily report de-identified data to the Centers for Disease Control in Atlanta. That list of nationally reportable diseases is dynamic, it changes. Now there are about 120 infectious and non-infectious diseases that are reportable to the CDC. The authority for the mandatory reporting of this data rests with the states that then are transferred to the Centers for Disease Control. So that's where we were so there was a lot of interest in public health surveillance data in the mid-50s. And then interestingly, particularly in infectious diseases, this graph shows crude death rate for infectious diseases in the United States from 1900 to 2000. And what you see, first you see that big jump, the 1918 influenza pandemic in death rates from infectious diseases, peaking there, but then a sharp decline in infectious diseases throughout the 50s, 60s, 70s, for a number of reasons, including the use of antibiotics, the Salk vaccine, polio vaccine, increased acceptance and use of vaccinations, and attention by the 60s, 70s, and 80s turned to chronic diseases, heart disease, cancer, and partly that may have led to an underinvestment in public health surveillance data because of because many experts began to feel that the worst was over with regard to the public health challenges of infectious diseases. Nobel laureate Sir MacFarlane Burnet wrote in 1972, on the basis of what has happened in the last 30 years, the most likely forecast of the future of infectious diseases is that it will be very dull. Outbreaks of fatal infections derived from exotic animals will doubtless occur in the future, but will be presumably safely contained. Now, that optimistic view was what has been clearly reversed by a number of emerging new infections as well as re-emerging pathogens, beginning in 1981 with the first case of AIDS that was reported here to Fatal Diseases Focus of Inquiry, New York Times, and in fact, one of the very first cases of AIDS was reported by a UCLA physician, Michael Gottlieb, and of course, that was the beginning of an epidemic that continues today. And there have been so many other outbreaks of infectious diseases: Zika, H1N1, Lyme disease, TB resurgence, anthrax, Ebola, COVID-19, most recently monkeypox, and on and on. So was our public health data infrastructure prepared to deal with COVID-19? So what is the data flow for public health surveillance data with COVID-19? And this schematic shows you how data flows, beginning when patients seek healthcare services, and ultimately how that data gets transmitted to the Centers for Disease Control. The big takeaway from this slide is that there are streams of data coming from multiple sources, which somehow need to get aggregated and put together and linked when there's data from multiple sources. So here you see in the first panel, patients are seeking healthcare services. Then in the second panel, they may go to hospitals or healthcare providers, emergency departments, laboratory and testing sites to get test results. They may go to a vaccine sites. And those data then are transmitted somehow to public health, local public health agencies that transform the raw data into usable person-level information. And that may be combined with vital records, which have to do with births and deaths, and also some demographic information. And all of that needs to be linked together. And then de-identified data in the step 4 of this panel 4 is sent to the Centers for Disease Control for national aggregation. And that's what forms a lot of the dashboards that you'll see either at state levels or at national levels. But there are issues with all of this. How do you, when you've got all these data streams from different sources, how do you correctly match or link records of the same person? So for example, you may have data from laboratories or from healthcare providers coming in. You may have data from vaccine registries who got vaccinated. You may have data from vital statistics, birth and death records. And you might be able to link some of those people, like in this case, this individual. But how is that linking done? In many states, it's based on your last name and maybe your address or other identifiers, but small misspellings, small typographical errors that you can imagine, you cannot link one person, the same person, from multiple data sources. In that case, if a misspelling, you wouldn't know that that individual here had a laboratory test. Or this individual that we've linked their laboratory test with some vital statistics records, but they don't appear in the vaccine registry. Were they vaccinated? Or maybe they may have been vaccinated, but it was not reported. So incomplete reporting into a vaccine registry may falsely lead you to say someone's not vaccinated when they really have. So there are a lot of potential holes in the data. and holes in the data, and particularly where there's incomplete or missing data in a lot of these data streams, and specifically about race and ethnicity information in national COVID data. Shows here are the different data streams coming in, public health data, and what percent are complete with regard to race and ethnicity. And you can see it's ranging from 29% to 77%. And particularly when you're trying to assess the burden of disease across all segments of our population, missing this data can give a skewed impression of what's happening. It's not only the missing data and linking data that's an issue, it's the timeliness of reporting of data. New York Times, June 2020. Bottleneck for US coronavirus response, the fax machine. Before public health officials can manage the pandemic, they must deal with a broken data system that sends incomplete results in formats that they can't easily use. Here, paper stacks of coronavirus test results in the Public Health Department, Harris County, Texas. Politico, April 15th, 2021. Inside America's COVID reporting breakdown. Crashing computers, 3-week delays tracking infections, lab results delivered by snail mail. State officials detail a vast failure to identify hotspots quickly enough to prevent outbreaks. In the beginning of the COVID pandemic, there was incredible public demand for trusted public health data. Data that was reliable, aggregated, both at local, national, and global levels. And one would have thought that the Centers for Disease Control would have been the trusted source for that data. What actually happened was that Johns Hopkins University developed a website, turned out to be one of the most highly trafficked website for public health data, both at the national level and at the global level. And in fact, last month, the 2022 Lasker Prize was awarded to the individual who developed that website, and it was the Lasker Award for the COVID dashboard, which set a new standard for disseminating authoritative public health data in real time, and cut through noise of misinformation, and became the most authoritative and trusted source of information for COVID-19. So public health surveillance data and having accurate, trusted data is really the bedrock or foundation for developing policy. But it's not enough, right? Because even if you had accurate data, you need to know what it means. And you need analysis and models of that data. And from that is what informs public health policy. So interpreting COVID-19 data, what is it that we're measuring? And what is the most reliable metric to use? Is it numbers of deaths? Is it numbers of hospitalizations? Of COVID, number of cases positive for infection, numbers of tests, the positivity rate of infection, which is the positivity rate refers to the number of positive infections divided by the number of tests. What percent of tests for COVID are actually positive? Each of these, the take-home message is each of these have a lot of subtleties in interpretation and nuances. and not to take things at face value. For example, this is the COVID-19 positivity rate in California in the very earliest phases of the epidemic, April through June of 2020. And what you're seeing here for that period, April through June, the blue bars represent the number of tests that were done for infection. The orange bar, the orange graph there shows you what percent of those tests were positive. So that's the positivity rate. And as you can see, the positivity rate was very high early on and then decreased to relatively low levels, which might have led some to believe that because the positivity rate was decreasing, might have led some to say, well, the epidemic was dying out. And in fact, though, that would have been an incorrect conclusion. Why? Because there are changing patterns of who is being tested. Early on in the outbreak, it was persons who were symptomatic. There were a limited number of tests. Not everyone could get a test. And the ones that were getting a test were sick, were symptomatic. So there was a selection, changing selection of who was getting tests. And so the rates were very high. And then as more tests became available, the positivity rate decreased. Now, of course, there are more issues with interpreting the data at a population level because of home antigen testing. People aren't even coming in to get their a test from a laboratory facility, which and all of that creates nuances in understanding what interpretation of the data. What do the numbers mean? Similar issues come in with counting hospitalizations. Initially, those coming in for hospitalizations were tested and they were coming in because of COVID-19. As the epidemic progressed and more tests were available, persons were admitted, but were being admitted for hospitals for reasons not necessarily connected to their COVID-19, and COVID-19 was discovered incidentally during their admission to the hospital. How do we count those? How do we interpret those? Similar issues with counting of deaths. Early on, it was deaths for many deaths were from COVID, but as diseases became less severe, deaths people were dying from other causes with COVID. And there's ambiguity about how to count those in interpreting the data. Public health surveillance data, an accurate understanding of it can have very, very important policy implications, particularly with regard to tracking COVID-19 vaccine effectiveness. You know, when we talk about vaccine effectiveness, the gold standard approach for evaluating effectiveness of a vaccine is a randomized controlled clinical trial. That's what the Food and Drug Administration uses. But randomized controlled clinical trials, although the most reliable, really also need to be supplemented by evaluating the real-world effectiveness of vaccines in public health surveillance data. And the reason that we want public health data to go beyond the experiment, the clinical trial, is because it helps answer the question, well, what's really happening in the population? We know that the vaccine works in a randomized trial. Is it working? Do we observe it working out in populations? Also, evaluating vaccine effectiveness outside of randomized trials allows us to assess, is there protection against new and emerging viral variants? So for example, if a clinical trial was done against one virus, and then in the future, now we have new variants arising, is that vaccine still effective? Well, you can track that if you have good public health surveillance data. Does effectiveness wane over time? Clinical trials only have follow-up over limited periods of time. Public health surveillance data allows you to follow in populations over long periods of time to see whether you're still protected over time. And not everyone is represented in clinical trials. So what parts of our community are not well represented or are underrepresented in clinical trials, and public health surveillance data can help monitor that and assess that. But the challenge in assessing vaccine effectiveness from public health surveillance data goes back to the data infrastructure that we have. We have to be able to accurately link immunization or vaccine records with COVID-19 disease records. And other countries have reliable networks of interconnected data systems to allow you to do that. United Kingdom, for example, Israel, ability to link records using unique identifiers. And we do not have reliable systems to do that. And in fact, in the peer-reviewed literature, the leaders of that were in assessing vaccine effectiveness from public health surveillance data, what's happening in populations were United Kingdom, Israel, and other countries, not the United States. Those were the first peer-reviewed journal articles coming out from these other countries, and the US was playing catch-up in providing that information, and then it was often done on an ad hoc basis, trying to pull together and cobble together and link data together. So now you have your data, you've done your analysis. What about models and the role of models? Models help you forecast and make projections of what is to come with regard to an outbreak or an epidemic. How big will the epidemic be? Now, epidemics forecast models, they come in two flavors. The first is, so this is how you take public health data and make forecasts. One are curve fitting models, and the second are more involved mechanistic models that account for the biology, the transmission dynamics of the pathogen, or the incubation period. So mechanistic models are using more information about the disease dynamic, whereas curve-fitting models just look at trends in what's happening. So I'll give you a couple of examples of this. Let's go back to the 1980s with some of the first projections of the AIDS epidemic. And this was one curve-fitting example, and they used Farr's law. It's the same Farr I referred to early on. And that law, and by the way, it's not really a law, okay? It says that epidemics, it purports, I'll say purports to say that epidemics follow bell-shaped curves. And there was an attempt made to use this bell-shaped curve to make a forecast of the AIDS epidemic. And this is numbers of cases of AIDS in the United States. And the solid yellow line is the data that they had. The yellow dotted line was the projection based on fitting a bell-shaped curve. So what do we see? We get the anomalous finding that the epidemic was going to be over by 1994. Not true, okay? Didn't work. This, hindsight, of course, is 2020, but the dangers of extrapolating curves is a very, very important message. All the data here, which is the solid yellow, was rising numbers of cases, and yet because of the forced shape of the bell-shaped curve, predicted that the epidemic was going to be over. That's a curve-fitting model. Here's an example of a mechanistic model of AIDS that tries to use some of the biology of it. And the basic idea was that of something called the incubation period. The incubation period refers to the time from infection, when you get infected, to the time you develop symptomatic disease, in this case, AIDS. Symptomless victims may spread AIDS for years. 1985, New York Times. So data was becoming available back then that mostly from transfusion-associated AIDS cases, that people could live a long time, get infected, and you didn't even know it with HIV infection before they became years and years. And that idea led to a model which was kind of the tip of the iceberg. If people are incubating the disease for a long period of time, and you only have a certain number of symptomatic AIDS cases in your public health surveillance data that have actually been reported, and if the incubation period is long and variable, that must mean there are a lot of people out there you don't even know about yet who are infected, that are have the virus and they're incubating it. And then you can imagine a little mathematical model to make that projection and say, what's the size of the whole iceberg here? AIDS must only represent the tip. There are a lot of unseen HIV infections out there incubating, and there's a lot more to come. And that led to some early work we had done on this, that projections for the US in 1986 indicate that the AIDS epidemic poses a major public health problem and that the epidemic will greatly exceed the cases reported to the Centers for Disease Control. So what are lessons learned from this? Certainly we must have learned something about the dangers of extrapolation in COVID-19. This is one projection that was done early in the epidemic in March 2020. Okay, so this was just really early in the epidemic. And the red curve there, this was done by a group, University of Washington. And the red curve represents numbers of deaths. And they fit actually it's more like a log normal curve here rather than a normal curve. And basically projected that by June 2020, the summer of 2020, there would be no more cases. So the dangers of extrapolation and using simple curves, the past does not always necessarily predict the future and depends upon the curve that you're using, which led me to write an op-ed in the Los Angeles Times, April 2020, about that projection. Predictions about where the coronavirus pandemic is going vary widely. Can models be trusted? To make predictions, curve-fitting models simply extrapolate curves into the future. Because of the pitfalls of extrapolation, the Institute for Health Metrics model projection of nearly 0 COVID-19 deaths this summer is not considered reliable and should be viewed with extreme skepticism. If you are looking for longer-term clues regarding how the pandemic will play out, pay attention to transmission models, even though they have their own built-in uncertainties. And in fact, this is the number of deaths in COVID-19 over the past couple of years, and you can see it doesn't look like a normal curve. It doesn't look like a log normal curve. It's complicated. It's a complicated thing, and you've got different waves coming in as new variants and new lockdowns and new things, and it's clearly certainly not a normal curve. So what do? Well, there are transmission models which try to model the dynamics of what's going on, and actually, what are these models? This is one of the first models was called the Reed-Frost epidemic model, and this is a Lowell Reed in 1951. There's a nice YouTube video of him doing a little science television show about what his transmission model was for epidemics. So if you have a chance, watch it. It's kind of neat, explaining his mathematical model for the dynamics of epidemics, and this is him actually demonstrating it, and he demonstrated it with a wooden trough. That's that wooden trough, and he took marbles, and he took different colored marbles, red marbles and blue marbles. The red marbles were infected people, represented infected people. The blue marbles represented uninfected, and he put it and he shook them up and poured it out on this trough. And every time a red marble came in contact with a blue marble, it represented infection. And he used this to propagate epidemics. Of course, that was done mathematically, not only with marbles, but today, of course, transmission models are done by highly intensive microsimulations called agent-based models. And you can see here different individuals represented in different social networks or communities, interacting both within their social network or families or schools or classrooms, and then interacting outside of their networks. And these computer-based models allow the propagation of epidemics and allow you to make forecasts, and also to evaluate policy implications, such as different lockdown procedures, lockdowns and masking and other interventions. What would be the implications of that? I do want to say that while these models are useful, they need to be made more transparent, because they often depend upon a lot of assumptions and inputs, such as inputs for what is the effectiveness of a lockdown? How does it reduce the transmissibility, transmission rate from one to another? And so those are inputs, and assessing the uncertainty in the inputs on which these models rely is important. This is another schematic showing here the blue are uninfected individuals, the green are persons who are immune to infection, perhaps vaccinated, and the red individuals represented infected. And as you can see here, as more people become immune or vaccinated, the persons who are infected have less of an opportunity to infect the blue individuals. And these kinds of models, these agent-based models, that allow you to evaluate what's called herd immunity, how many people in a community need to be vaccinated, and what the impact of that would be on the rest of the community. So what is the current status of public health surveillance data right now in the United States? Monkeypox, July 2022, CDC Director Rochelle Walensky, referring to the new threat that we were seeing, saying, inconsistent data inhibits the agency's ability to observe trends in race and ethnicity, sexual behavior, and vaccination. And yet again, like we were for COVID-19, we are again really challenged by the fact that we at the agency, the CDC, have no authority to receive those data. So how is this happening? There have been so many advances in health data in the past decade. Digital health and information technologies, computing platforms, improvements, mobile health, wearable devices, radiological images stored and viewed digitally, prescriptions that are transmitted electronically, artificial intelligence used in radiology, early disease detection, telemedicine, smartwatches, so many advances in health data. The health information technology for Economic and Clinical Health Act, the HITECH Act in 2009, digitalizing, what he did was encourage the digitalization of healthcare delivery, provided incentives for the use of electronic health records, accelerated the use of EHR, electronic health records, and in the past decade, over $38 billion in incentives were done to improve that. But what about public health data systems, which is different than health data systems? There's been an underinvestment. It's not been modernized, fragmented. You've got data streams coming in from healthcare providers, hospitals, and labs, more players, clinics than you can imagine, testing sites all over 3,000 local public health departments, 60 state and territorial public health departments. And what you've got is a jumble of data standards, technology, and as we saw, data streams coming in from phone, email, and fax, siloed data systems, very difficult to match or link individuals from one data stream to the next, data gaps, especially in race and ethnicity. So what's the way forward? Well, we need to invest in public health. And not only when there's a public health emergency. It's too late. And public health only seems to come to the forefront when you've got a pandemic or a crisis. But if we want to be prepared and get ahead of it, we need to invest now. We need to improve public health data interoperability and data exchange between the players. We need to standardize data elements for data exchange and be able to share and link data from different data streams efficiently and in a timely way. Of course, respecting confidentiality and privacy. There needs to be much stronger coordination at the national level, in the Centers for Disease Control specifically. Now, there are various initiatives underway to make these improvements, so we'll see. I wait and I'm hopeful, but we'll see how all of this pans out. And it's not only about the data, it's about partnership of experts from many different fields. You need information technology experts to make your data systems interoperable. But you also need epidemiologists who understand the nuances of the data, the selection biases in what's being reported. You need public health professionals or practitioners who work with communities and build trust in collecting that data, statisticians and modelers to develop transparent models that it's clear what assumptions that they're making, communication specialists so that you can communicate what we know and what we don't know to the public about what the data means and how reliable it is. We need to develop connections between private and public sectors, and we've seen that more importantly in COVID-19, the gap between the business and public health communities, and we need leaders that can build trust in the data that we have and the direction that we're heading. So, future challenges. The good news is that in the last 100 years, we have made great progress in improving public health data. Data is a key element to the progress in public health. It allows us to measure and track the health of populations. And the importance of good public health surveillance data for measuring, accurately counting, and reporting of health data cannot be overestimated. It's really going back all the way to John Grant, allowed him to study mortality rates, and William Barr to study smallpox and cholera epidemics. And public health surveillance data is what actually provided the basis for the first AIDS projections in the mid-1980s, which helped call public attention to the extent of the epidemic in the first place. Our challenges continues, whether it's COVID-19 or monkeypox or now even polio. And if history teaches us, there will undoubtedly be future epidemics of old diseases resurfacing or epidemics of new diseases. And when there is a new public health crisis, we must be prepared. We don't have the luxury of time. Having reliable public health surveillance data systems in place to sound early alarms of emerging problems is critical. Public health data provides us the compass for designing, analyzing, and interpreting scientific studies, and it provides the evidence base for sound public health policy to address our current and future global health challenges. So with that, I'm just going to conclude with some readings, some additional material. The first one is about transforming public health data systems, a nice report from the Robert Wood Johnson Foundation. Another second one is on digital health and lessons learned. That's a report from the National Academy of Medicine. CDC has a report on public health surveillance and data modernization initiative, modernizing the U.S. public health system from the Bipartisan Policy Center, and then a nice paper in the New England Journal about models and what they can and cannot tell us specifically with COVID-19. So with that, thank you all very much.
Thank you so much, Dr. Brookmeyer, for this fantastic talk. I'm going to give Brooke just a minute to go ahead and stop our recording today.